Hello everyone. Thank you for joining today's 2019 QCDR Measure Workgroup webinar, Session 2, QCDR Measure Review Process. The purpose of this webinar is to provide an overview of the Quality Clinical Data Registry Measure Review Process for Year 3 of the Quality Payment Program. Now I will turn it over to Sophia Sugamar, Health Insurance Specialist in the Center for Clinical Standards and Quality at CMS. Please go ahead.
Thank you very much, and good afternoon, everyone. Welcome to the call. Thank you for attending. This call is directly related to our QCDRs, or Qualified Clinical Data Registries, who are known as third-party intermediaries and MIPS. Please note this call, the audience we intend for this call is those that are Qualified Clinical Data Registries already, or those organizations that are looking to become Qualified Clinical Data Registries. This call is not specifically on measure submission, and we are not addressing policy-related questions that are outside the Qualified Clinical Data Registry spectrum. And please also note that this call is not intended for individual eligible clinicians or groups. This is specifically for organizations that intend on becoming a QCDR, and those are typically large health collaboratives or large healthcare delivery systems or specialty societies. And there are entities that collaborate sometimes with the health IT vendor to become a QCDR as well. So with that indication, I'm just going to turn the call over to my co-lead and our quality lead, Dr. Dan Green, to get us started. Dan?
Thank you, Sophia. Welcome, everybody. Thank you all for dialing in on this kind of cold March day, I guess, depending where you're calling from. But I saw this morning 220 million of us are going to be below freezing today. Doesn't seem right in March. But anyway, can we move on to slide 2, please? You'll see our typical disclaimer. And then slide 3, please. And slide 4 now, please. Okay, so just want to briefly go over the agenda today. We will be talking about QCDR requirements, the QCDR measure process. So hopefully you'll find some helpful hints in terms of what we're looking for in measures, and then an idea of how we actually go through and review these medications. We do want to try to increase your understanding of the QCDR measure review process and the expectations, in as much as we think that will save you all some time in terms of your measure development, and equally the frustration sometimes when measures are not approved in the program. So we're hoping by having sessions such as this, we'll be able to improve the acceptance of the measures, improve the measures themselves, and obviously decrease disappointment. At the end, we will go over resources available, and we will have a question and answer session. So with that, I'm going to turn it over to Anastasia to continue with the presentation.
Thanks, Dr. Green. My name is Anastasia Robin, and I'm with the MIPS QCDR Registry Support Team. I'll be discussing a few of the overarching QCDR requirements needed or necessary to be able to act as a QCDR before passing the ball off to my colleague Jocelyn to convey some additional information related to the QCDR measures themselves. So with that being said, we'll start on slide 6, where we will discuss the new or enhanced definition of a QCDR for the 2020 performance period of MIPS. The rule for the 2020 performance period did go ahead and expand the definition to define it as an entity with clinical expertise in medicine and in quality measurement development that collects medical and clinical data on behalf of a MIPS-eligible clinician for the purpose of patient and disease tracking to foster improvement in the quality of care provided to patients. An entity that uses an external organization for the purposes of data collection, calculation, or transmission may also meet that definition of a QCDR as long as the entity does have a signed written agreement that specifically details the relationship and responsibilities of the entity with any external organizations, effective as September 1st of the year prior to the self-nomination, of the year prior for the entity seeks to become the QCDR. So if you're wishing to self-nominate to participate for 2020 as a QCDR, then you would need to have any agreements on file prior to September 1st of 2019. In addition to that, CMS does expect that entities without clinical expertise in medicine and quality measure development experience that do want to become a QCDR would need to collaborate and have these relationships or align with those type of entities that do have such expertise. These entities may seek to become a QCDR in collaboration, or as it says here, may seek to qualify as another type of third-party entity, such as a qualified registry. Becoming a qualified registry does not require the level of measure development expertise that is needed to become a QCDR that develops measures. Moving on to slide 7, some additional requirements needed to be a QCDR. You must have at least 25 participants by January 1st of 2020. Those participants are defined as having clinicians submitting data to your QCDR for the purposes of quality improvement. That does not mean that all of those participants have to be using the QCDR to submit MIPS data to CMS, but they definitely must be submitting that data to your QCDR for the purposes of quality improvement. In addition, we have something called the certification statement. During data submission, you must certify that the data you're submitting is true, accurate, and complete to the best of your knowledge, including the acceptance of data exports directly from an EHR. If for some reason a vendor becomes aware of any submitted information that is not true, accurate, or complete, you will need to correct information promptly and understand that knowingly omitting, misrepresenting, or falsifying any of the submitted information, you may be punished by criminal, civil, or administrative penalties, including fines, civil damages, and/or imprisonment. Of course, our QCDRs are responsible for data submission. Through data submission, you must submit the quality data to CMS using one of the approved secure data submission methods, such as a quality reporting document architecture file, which would be QRDA. They do accept the QRDA 3s at this point in time, or the quality payment program data formats like a JSON or an XML file. In addition, the QCDRs are required to have both a data validation plan and a data validation execution report. You must provide a data validation plan during self-nomination, and that file will describe how the data you're accepting from your eligible clinicians or groups or virtual groups will be validated to ensure that it is true, accurate, and complete. With that plan being due during self-nomination, when you self-nominate to be as a QCDR, on the other hand, the report that I discussed is the results of you actually executing that data validation plan. And so the execution report is due by May 31st, the year following the performance period. So for the 2020 performance period, the execution report would be due May 31st of 2021. Moving on to the next slide.
Hey, Anastasia, there's one clarification to the previous slide. For 2020, there was a discussion, or the first bullet point was about the 25 participants. To clarify, for the 2020 performance period, it's that there must be 25 participants by January 1 of the year prior to the performance period, so that needs to be updated, but that is the clarification we want to make there.
Thanks, Sophia. I appreciate the clarification there. We'll get that updated. Let's see, slide 8. The top of slide 8 does talk about the measure requirements to participate as a QCDR. If you do wish to support or to act as a QCDR, you will need to support at least 6 quality measures, including at least 1 outcome measure, or if an outcome measure is not available, you must use at least 1 high priority measure. In addition, you can elect to support a MIPS approved specialty measure set. To expand upon the outcome measure or high priority measure information we just reviewed, we will expand the definition of the high priority. So high priority measures are defined as outcome, appropriate use, patient safety, efficiency and cost reduction, person and caregiver centered experience and outcomes, communication and care coordination, and opioid-related measures. Opioid-related measure is a new high priority type for 2019. An example of that, if you'd like to take a look, would be quality measure 408, opioid therapy follow-up evaluation. Moving on to slide 9, we'll discuss a little bit more in depth about these types of measures that QCDRs can support. So QCDRs may host any MIPS clinical quality measure and or up to 30 QCDR measures from one or more of the following categories. National Quality Forum endorsed measures, as well as current 2019 MIPS clinical quality measures that are specified for a different submission method. For example, a QCDR may submit an ECQM version of a measure that may already be a MIPS clinical quality measure. In addition, QCDR measures developed for or used by boards, specialty societies, regional quality collaboratives, or large healthcare systems. All QCDR measures must be submitted for consideration during the self-nomination period for CMS review and approval for potential inclusion in MIPS. And please note that 2020 self-nomination period will occur from July 1st through September 1st of 2019. Information will be available on the CMS website related to that self-nomination period. And the final slide that I'll mention today is just detailing the the QCDR measures a little bit more in depth. So QCDR measures are typically clinically relevant measures that address gaps in care for specialties, preventive care, and or disease management. They're measures that aren't contained in the annual list of MIPS clinical quality measures for applicable performance period of MIPS. They can be a measure that's in the annual list of MIPS clinical quality measures that has substantive differences in the denominator or the manner it's collected, and publicly reported for QCDR data on Physician Compare expands the quality measure data available for eligible clinicians and group practices regardless of specialty, and provides more quality data to consumers to help them make informed decisions. Also, it provides specialty-specific measures and the partnership with the QCDR to lessen the burden for MIPS reporting. With that being said, we'll move into more discussion related to the QCDR measures and expectation, and with that, I'll turn the call over to Jocelyn Meyer to convey the next few slides.
All right, thanks Anastasia, and thanks again to everybody who's joined the second part of our two-part series. Next slide. We are really going to take a deeper dive in the process of the QCDR measure review and the expectations. This first slide is really just looking at the process of QCDR measure development and how it flows through the self-nomination and what happens behind the scenes. QCDRs, we ask that they work to develop QCDR measures prior to self-nomination. And we do have the option to request the measure concept preview call with CMS and the PIMS team prior to self-nomination. You are able to request a time slot up until 2 weeks prior to self-nomination closing, or beginning, sorry. So that will be in mid-June that would close. CMS will publish a QCDR requirement handbook on the QPP website, and last year this was known as the toolkit, and it contained a number of resources for QCDRs and measure guidance. And we are tracking to have this available in May. So once the QCDR is vetted by the appropriate teams, so we have a team that will take a peek at your actual self-nomination as an organization, and we also have a team that takes a deeper dive into the actual QCDR measures. And then throughout the self-nomination, QCDR measures are reviewed, and the teams may reach out for clarification. However, all measures will need to be reviewed prior to approval. This will happen in the weeks following the self-nomination, and the approval will take a couple different steps. So you may either receive approval or a provisional approval or an opportunity to revise based on CMS and PIMS team feedback. There may be instances where a QCDR measure may be rejected, but a rationale will be provided. For the measures that were rejected that were not topped out, QCDRs do have an option to request a reconsideration call. Once all decisions have been provided, you will be given a specification file for review and approval. We will be including the supporting QCDRs that have indicated they have permission for vendor review. This was a request that we've received from established QCDRs in recent years, so we are taking that step. And lastly, the QCDR measure specification file will be published prior to the 2020 performance period. Just to note, once posted, additional revisions are not likely to be accepted, as this should have occurred in the approval process. So next slide, please. The first thing we'll take a peek at is the review of the QCDR measures and the considerations. One of the first things considered during the measure review is the measure QCDR, or is the QCDR measure evidence-based? Are the guidelines summarized and cited within the self-nomination submission? And does the measure submission include a summarized and cited evidence of gaps? So we will likely reach out and ask if there is this information is omitted. Other things considered is, does the QCDR measure address one or more of the 6 national quality strategy priorities? Meaning the patient safety or the caregiver-centered experience and outcomes, communication and care coordination, effective clinical care, communication or community and population health, and efficiency and cost reduction. Next slide, please. Additional items that are considered are, and these are not in any particular order, but the measure should have performance variation. A measure should not have a high performance rate or lack of a performance gap. So when we say that we are looking for measures that have at least less than 95% or performance rate, or for an inverse measure, have a performance rate greater than 5%. In addition to evidence being, if the high performance rate and minimal variance measures are submitted, they will likely not be approved, because they do not allow for meaningful measurement or benefit to the clinicians. We need to be able to delineate between the good and the quality health care provided. In addition, if implemented, could there be any potential harm due to unintended consequences? If so, the QCDR measures would not be approved. We would not approve any measures that address never events, and I think we've mentioned this in the last presentation where it was the fire in the operating room, and you've probably heard this time and time again. These rarely happen, and so it's not a measure that can really address quality between clinicians. And lastly, measure should have the intuitive measure construct. You might hear this word a lot, but we want to ensure when looking at the measure or the description that you can quickly identify the intended patient population and exactly what the quality action is. Next slide, please. So when we take a look at new and existing measures, we look at the entire list of submitted measures for the year, and we'll look to see if there is a similar if it is similar to an identical or retired PQRS or MIPS clinical quality measure. If we identify that there is a related measure, we will likely not approve. Another rationale would be similar or identical to an existing MIPS quality. It's already been in the program. CMS would request to report the MIPS clinical quality measure for that clinical area. One caveat is if there is a particular setting that's not represented within the MIPS measure, we may allow that, and then we do try to work with the measure steward to incorporate that setting in future program years. Or there may be a similar QCDR measure that was previously rejected. We will have measures submitted year over year for each self-nomination, and we actually look back to all the years of QCDR measure submissions to make sure that we are consistent, and CMS will not likely approve measures unless there's been some sort of modification to require more meaningful quality action, or there is, or you can prove that there is a performance gap. We may look to see, or we may identify a similar or related to a QCDR measure submitted by the same QCDR. CMS would ask that QCDRs combine multiple QCDR measures into a broader denominator or multi-strata, or maybe perhaps a composite measure, which we did review how to construct those in the earlier presentation. Next slide. Again, for new and existing measures, if a measure was submitted that disjoins a single quality action into individual steps or delineates individual complications or outcomes of care associated to a specific procedure, we typically would request that QCDRs would consolidate the series of measures into a single composite or combine the quality action. This leads to more robust measures that will likely result into providing more meaningful data to clinicians. If a measure is submitted where it does not have a quality action, we will likely not approve the measure. So what we mean by that is that the clinician would perform an assessment of a disease, but there's no additional quality action. There's no follow-up. We would look to see that there was appropriate guideline-indicated treatment or some sort of plan of care at minimum. And lastly, for new and existing measures, if a measure is submitted that is an NQF measure, we will not recognize it as an NQF endorsed unless the exact measure specification is used and there's no variation. All right, next slide, please. We're on slide 16. Each self-nomination, we do receive a number of patient survey measures. CMS will request that these measures be modified to be about patient satisfaction and not just the collection of a survey. So we don't want a survey that would actually reward or does not, an eligible clinician could actually score well even though the survey results indicate poor quality. So we just want to make that note that we want these to be reflecting the patient satisfaction. QCDR measures that do not align with the MIPS scoring methodology, CMS will request that the measures be respecified to reflect that 0% for inverse and 10% indicates better clinical quality or control. And lastly, if a QCDR measure that does not demonstrate room for improvement and is topped out, we will not approve those. And as I had mentioned earlier, that would be above that 95% performance rate or less than 5% for inverse measures. Next slide. If a facility-based measure is submitted, we'll not approve this type of measure. We do acknowledge that there is value in pursuing facility-based measures, but the measure must fit within the constraints of MIPS quality, where the attribution must be made to a single eligible clinician or group. That being said, we do have measures submitted every year that the quality action does not, it's dependent on actions of others and not being not attributed to that eligible clinician. So we would provide that in the rationale of the rejection notice. And middle one is if a QCDR measure is better suited as an improvement activity, we would provide that clarification to submit to the call for measures and activities, which is actually just opening up on the CMS website this past week. So that would be a good avenue for those types of measures. Next slide. These next few slides are really going to pertain to the existing QCDR measures. This first one is resubmits a measure that has limited adoption. So we are looking at measures that have been approved for multiple years, but they still only have 4 eligible clinicians that are submitting the measure. What that means is there's no ability to benchmark, and there's a very small cohort, so you can't really compare and provide scoring to those types of measures. So we are taking that in consideration when we're receiving and reviewing these measures if they have adoption. That doesn't mean that you can't continue to collect the data, and once that measure adoption has picked up, resubmit, and we'll definitely review. All right, the next existing measure, is the non-compliance with a request from a previous self-nomination. So each year when you receive the measure decisions, there may be some request for harmonization, performance data, some sort of action item. If this is not completed and there's not a valid justification, CMS may reject the measure. Next one is the feasibility or unable to implement the QCDR measure or abstract the data at the time of submission. So we have taken this and have really been trying to identify these measures that are unable to be collected, whether it be they can only establish the patient denominator or patient population, but they can't quite abstract the numerator. We would reject those until they actually could be implemented and feasible. And the next one is substantive changes were made previously to approved measures that may not allow comparison from previous performance data. And we'll dive deeper into that in the next slide, but CMS will identify these measures as a new measure and assign a different ID purely for benchmarking purposes, and we'll detail that out in the next slide. So we can move on to slide 20. All right, so when a QCDR measure was approved from a previous performance period but has undergone substantive changes that would not allow comparison from the previous performance data, we would provide a new measure ID. An example of substantive changes would be revised care setting. Maybe in the year prior it was just your general outpatient E&M visits, but then the next year we request or maybe through measure development you decide to expand to an anesthesia procedure coding, and it changes the measure drastically. We would assign a new measure ID. Or if the intent of the quality action has changed, maybe from patients who had an assessment 2 months post-procedure, and then the following year it was the number of patients who showed a 10% improvement in functional ability 2 months post-procedure. We went from a process to an outcome, but it would definitely impact performance. So we would definitely want to provide a new ID. And the last one is the analytic designation. You may have revised the measure or respecified so it's no longer inverse, or perhaps you went from a ratio to a proportional or a continuous variable to a proportional, or you have implemented risk adjustment. Those would all require a new measure ID. We do have a series of questions within the measure template that asks for input and for the necessary changes, because that's not always clear within the measure specification. Next slide. We'll now touch upon harmonization. I lost my slides. Can you see? I think we're on slide 21, and I'm not seeing slides come up yet, so we'll give it a minute.
Apologies for this technical glitch. We'll try to get this sorted.
Well, while we wait for that slide to pop up, we can just start to review the harmonization. So each year we receive a number of measures that may be closely related, maybe just a slight variation. We would likely ask you to work with the other QCDRs to harmonize similar QCDRs into a single measure, and that allows for a larger cohort to be involved. Okay, we're just going to wait. Sorry. Okay, sorry, we had a little technical issue on our side. We aren't able to see the slides, but we're receiving word that you guys can. So we'll start over on the harmonization. There are a number of measures each year that are maybe one-off, the same clinical topic or quality action. We would ask that QCDRs harmonize. Harmonization between QCDRs provides eligible clinicians a bigger cohort and compared across the performance scoring and benchmarking. If there is a compelling reason for not doing so, we would just ask that you provide that within your self-nomination and a detailed justification. If a separate QCDR submitted a measure with a similar population that assesses a complete set of quality action, then the QCDR may be asked to request to use that more robust measure as opposed to harmonizing. So there is a difference between harmonization and requesting permission, but it would usually occur when multiple measures with essentially the same focus and create a burden and confusion in choosing measures to implement when interpreting and comparing the measure's results. Measure harmonization is defined as standardizing specifications as having the same measure focus, would be the numerator criteria or the same target population, and applies to many measures. We do request that QCDRs collaborate amongst themselves, and CMS isn't able to mediate these harmonization requests, but prefer to leave it to the QCDRs to determine the best approach. We are definitely open to discuss a newly harmonized measure in a preview call, but if you do run into roadblocks, please make sure to, as I stated, outline your efforts when you submit the measure for consideration. And next slide, 22. The blueprint, this is a table provided by the blueprint. It offers sort of a crosswalk of the expectations of harmonization. So for instance, it's looking at the numerator, and it has the same measure focus, but it has a similar measure focus, and the denominator is the same. They'd be considered competing measures, and we would ask that we would choose one QCDR measure to use, and the other entities would request permission. There may be instances where they're related, so the numerator is the same measure focus, but the denominator has different target populations. We would request that they harmonize and re-specify by expanding the target population, or again, justify the differences. And there's also related measures where the numerator is a different measure focus but the same target population. In this instance, we would harmonize the harmonization of the target population or justify the difference of the measure focus. Next slide, please. Now, we had touched upon provisionally approved measures in the beginning, but you may receive a couple different rationales for that provisional approval. In the subsequent self-nomination, we would request that you provide performance data to substantiate there is a performance gap or room for improvement. Other times, we may ask you to combine the measures into a single composite or maybe a multi-strata, or even just broaden the denominator. Again, we have, as we just discussed, the harmonization. We do allow, sort of differentiate between the two, minor and major. For this last year, when it was identified as a major harmonization, we allowed that additional year since we are moving up that self-nomination timeline. But those minor self-harmonizations, we did request that that be completed prior to the 2020 self-nomination. In addition to, we may provisionally approve a measure and request that you modify the measure, for instance, create a more robust quality action or change the age range, things of that nature. If the CMS request for revision was completed, the measure will be reviewed and likely approved. We will say that if a new measure comes in and it's even more robust or has a broader denominator, just because you made that revision does not mean it's automatically reviewed, because what we are doing is looking for the most robust QCDR measure set. And if you do not comply with the request, the measure will likely not be approved. Next slide, please. And I think we are on slide 24. I can't see the slides, but we are nearing the end of our presentation. And I'll hand it over to Marla. So if you have any questions, feel free to submit them through the Q&A, and we'll get those addressed. But Marla, I'll turn it over to you.
Thank you. If you would turn to slide 25. This is the resource on how to set up and prepare for a measure concept preview call. It's been mentioned several times throughout the last two work group sessions about we really encourage you to take this opportunity to go over your any new measures that you are developing, as well as any measures from the previous period that were provisionally approved, and make sure that what you were modifying is appropriate so that it has a better chance of being approved again. So to request a call, you just send an email to qcdrvendorsupport@gdit.com. You can look on the Google Calendar, and it's just strictly shows you the dates that it's available, and it's essentially May through June. It'll also show you the last date that you can request a call. Then in the email you include basically a 2-week period, include several dates and several times that you're available, and then it will be coordinated with Dr. Green and Sophia's schedule. And then you need to include email addresses of all those from your team that you would like to attend. You need to, at least at 1 week to your scheduled meeting, you need to send in a single document, either Excel or Word, not PDF, so that we can use that document to do our analysis and then be prepared and make your call as meaningful as possible. There's also the QCDR Measure Development Google group, and this is a space for QCDRs to reach out to each other to work on some measure development processes, harmonization, that kind of thing. The next two slides, slide 26 and slide 27, are links to different resources that you can use, such as the blueprint, etc., to look for, again, resources for the measure development process. I think now we're going to enter into the question and answer session of this presentation.
We will now go into the Q&A session. For those who are looking to have their questions answered, we will be taking all questions from the chat. So if you have a question, please make sure you put it in the chat box. And I think we'll go ahead and get started with one of the first questions. We'll work our way bottom to top. So the first question we have comes from Randy Kudner. How are measures reviewed for inclusion if the QCDR owner is not the steward? Attestation of measure licensing is part of the self-nomination process, but is it actually reviewed?
So we actually don't require that information to be submitted. However, new for 2020, we have heard from QCDRs or measure owners that some entities maybe have indicated they did have permission, but in reality they didn't. So we are taking steps to mitigate that, and when you receive your measure specification file, that actually will be included the additional entities that say they had permission into your measure approval or measure specification approval, and so that way you know who has indicated to us, our team, that they have permission.
And in addition to that, when a QCDR self-nominates and includes a measure that belongs to another QCDR in their measure template, and in that template it asks whether or not you have permission, and they're indicating yes, and if we come to find that's falsified, that could also have preceding consequences for that QCDR, whether that impacts their participation in a future year because they falsified information. So that's another thing we will consider. So though it's only an attestation, if we come to hear from other QCDRs who own the measures that they have not given permission to those QCDRs, and the QCDR who indicates they have permission is not able to produce documentation to support that, that can impact their future or their current or future participation in MIPS.
Okay, and the next two questions also come from Randy Kudner. CMS approved a QCDR measure related to a MIPS measure that was removed as extremely topped out. What is the rationale of that?
Yeah, and I think I'm going to make a leap just by who the society represented. But I believe the measure you're referring to, the QCDR had altered the measure to include a different patient population or treatment, and then in addition tweaked the quality action. And we did request that they provide performance data substantiating a gap prior to approval. So I think, I'm just assuming that it's one of the radiosurgery measures, but that was all taken into consideration.
Okay, and then the final question, does the NQF measure need to be currently endorsed?
Yep, in order to have the NQF endorsed ID within this measure specification, we'd ask that it only be those that are currently endorsed.
And just to clarify, QCDR measures are not required to be NQF endorsed. However, if you were going to submit an already approved and a measure that's gone through the NQF endorsed process and has an NQF ID assigned to it, we'd expect that that measure be, when you submit that measure NQF ID with the measure, that that measure ID reflects that the measure is currently endorsed and you have not made any alteration to the measure specification that would then require us to just say that that measure is not an NQF endorsed measure. It doesn't reflect the specifications that went through the MAP, the NQF process.
Okay, the next question comes from Kimberly Smuck. I noticed that you spoke to the QCDR measures needing to meet an NQS domain and not meaningful measure area. Is there a reason that the meaningful measures framework wasn't addressed?
Great question. That was actually covered in the first session. So we did address it there, and that is a question that we asked that QCDRs identify which meaningful measure the measure addresses or relates to during self-nomination.
Okay, our next question comes from Orla Sheehan. Question about patient survey measure. Your slide gave an example of a quality action as an improvement in a patient's condition. Would making a plan of care also be a quality action for this type of measure?
as you know, CMS prefers outcome measures, so we like to see that there's an improvement or some sort of patient satisfaction. Adding a plan of care, we would consider that a process measure. It would be considered, but just know that we do lean towards outcome-based measures.
Okay, and a follow-up to that question. On tapped-out measures, you expressed a view that at least a 5% gap was necessary. Last year, we had a measure rejected that had about a 10% gap. Has CMS changed this criterion?
No, this was, the 10% gap or 5%, there may be other considerations outlined within your rationale that the QCDR measure was not approved. So we do look at any of the performance data submitted to MIPS. We look at the benchmarking. We look at data provided by the vendor. So there's all different data sources that come into play. If, for instance, we do reject a measure and we see it as a topped-out based on the data we have, but you're able, you can always request this. Well, we don't offer reconsiderations, but you can provide that data. But if you receive that rejection and it was indicated as topped out, it was based on MIPS data or benchmarking data.
And so to that point, if you are able to provide additional data that demonstrates there is a gap after we've identified the measures topped out, we would consider the data. But typically, we don't have reconsideration calls for topped out measures, as Jocelyn said.
Okay, moving on to the next question from Diane Bankston. So for measure harmonization, if you wanted to use an existing MIPS measure and add a new additional quality action for an additional strata, then would that be a new measure or one that would be would need to be harmonized?
So a MIPS measure. So there's multiple things to consider here. We don't want a lot of one-offs. We will say that. So we don't want a blood pressure for like different disease processes. So it's not black and white. But if you saw a MIPS measure and wanted to add a new quality action, you could submit it and we would review it. I would definitely take this one to a measure preview call, just because I'm not sure exactly.
We'd also want to give consideration or preference if you could possibly reach out to the measure owner and provide your recommendation of what you would change to the measure. As Jocelyn said, we're trying to avoid duplicative measures in the program, so as much as we can have comprehensive set where there's less measures that are similar in concept, that's what we're looking for. So it really is dependent on how you are changing the measure. We can't just generally say that that will be considered to move forward in the program. Our preference is that we consolidate measures. So one of our requests is if you are able to provide those requests to the measure owners themselves to take into consideration, that might be an update that they will take into consideration prior to it actually becoming a QCDR measure.
Okay, the next question comes from Hiran Dave. When quantifying a performance gap, must the gap be defined from our QCDR's data, or can the gap be defined from the literature?
We would ask that if both are available, we'd ask that both are provided. In the event that you have limited data, but you can substantiate a gap through a study, you are able to provide that. The one caveat that I will say is what we see a lot is a study will be provided and it'll validate the importance of the measure, but it really doesn't speak to there is a gap. So if you do provide that study information, we just want it to make sure it reflects the quality action being measured within that QCDR measure.
And Jocelyn, do you want to touch on the relevance of the study, how current it should be?
Yeah,
clinical evidence?
I think last week we said it was within the last 5 years or the most recent. So.
And as a reminder, if you have any questions, please make sure to send them through the chat. We have 5 more minutes left for the webinar, so there's a couple more minutes to answer questions. So please make sure you put them through the chat.
Okay, guys, last call for any questions. I'm assuming we don't have any more. Is that right?
I don't see any coming in.
Okie doke. Well, I want to thank everybody for your time today and for the great questions and your attention. We will look forward to speaking with those of you that are QCDRs on our next QCDR support call. Please do remember to submit your data early and often. We have just a few weeks left for data submission. So thank you, and we will speak to you in a few days or weeks. Have a good day.